Hi, I'm Dr. Deepak Megur, and today we have a very challenging case. She's a 90-year-old lady who has this very hard brown cataract, and to add to it, she has dense pseudoexfoliation and a non-dilating pupil. There is this clear space between the iris and the lens, and suggesting that the zonular health also might not be great. There is no evident phacodonosis at the lab examination. But looking at this case, it's quite challenging in the multiple challenges to deal with. Number one is to visualize properly. The pupil is a hindrance. Number two, we have an extremely hard cataract. And looking at the extent of pseudoexfoliation, what we're seeing, the zonular health might not be great, suggesting that it might be very difficult to perform rhexis and in fact even save the bag. The fourth challenge also is regarding the corneal endothelial health. Now, this patient being an elderly lady, and we are going to maneuver a very hard nucleus. So with all these complexities in mind, I am made certain plans for this. So number one would be to take care of the pupil. So I'm going to use specifically the capsule hooks, not the iris hooks, to stretch the pupil, because I can use the same hooks to support the bag if the situation demands in case of a generalized zonular weakness. And since the nucleus is extremely dense, I am avoiding phacoemulsification in this case simply because the effort required to divide the nucleus into smaller fragments can worsen the zonular weakness which is already pre-existing. That's the reason I am choosing to do manual extraction of the nucleus. And of course, I need to be watchful about how the capsule behaves and then take a call on whether to insert a CTR or no. In the worst case scenario where I'm going to lose the bag, I have kept the appropriate powered iris clip lens ready to be implanted in this eye. When I decided that manual extraction of the nucleus is my choice, there is no option of using a pupil-based expansion device. I have to resort to either capsule hooks or iris hooks, and I have preferred to go ahead with the capsule hooks in this eye. 2 ml of lignocaine is injected in the posterior subtenon space. Conjunctival flap is created. The bleeder vessels are then cauterized. As is customary, I make my posterior scleral groove, which is used primarily for fixating the globe. And then a frown-shaped 7mm scleral incision is made, the center point of which is about 1.5mm away from the limbus. The sclerocorneal tunnel is fashioned. Now is the time to make the paracentesis for the iris hooks. The plan is to make 4 paracentesis incisions. When we're using iris hooks or the capsule hooks, we don't want the intracorneal tunnel to be very long, and typically I would like to have them much more posterior, that is at the posterior limbus or beyond it. And the intracorneal length has to be very small so that inserting them and pulling them out will be much more easier. I'm going to use these proximal paracentesis incisions, which are nearer to the incision, the left and the right, for my bimanual I&A. So I need to stain the intercapsule now, which is being done under the cover of air bubble. But the problem is the capsule which is underneath the iris is not going to be stained well, and I'm reluctant to push more dye behind the pupil because there is a lack of space, and also I'm worried that the fluid can percolate across the zonules and go behind into the burger space and might increase the pressure. But if the capsule which is behind the pupil, it doesn't get stained, then it might be difficult for me to identify the rhexis edge during nucleus manipulation. Let's see how things turn out. The antechamber is inflated with OVD and time to place the hooks now. While introducing, care is taken that the hooks are placed horizontal and then they are slid into the antechamber through the port, and then they are turned so that the flange of the hook goes and hooks the pupil. Now, care is taken not to pull at these hooks. We just want to engage the pupillary margin now and not pull it towards the limbus. The opposite hook is then placed, and now all the 4 hooks are in situ. Now, as we can see, I have not yet put any stretch on the pupil. I'm just engaging them. So I'm going to only pull these hooks at the end when it's really required me to see well at the periphery. Using a sharp bevel up 2.8 millimeter keratome, the main entry is done. The internal entry is then extended laterally on either side until the entire span of the sclerocorneal tunnel. Now the fifth ring is placed through the main incision itself. It engages the 12 o'clock pupil and then it is stretched. The pupil is now around 5 mm dilated with these hooks. Time to perform the rhexis. The moment I touch the anticapsule, that's the time I'll be knowing the health of the zonules, how good or how bad they are. So I'm using a bent 26 number needle to puncture that anticapsule, and the moment I touch the anticapsule and try to puncture it, there's a slight movement of the lens suggesting that there is some amount of zonular weakness. The sharp cutting edge of the needle is helpful in puncturing the capsule and raising a flap. I switch my needle with the capsulorhexis forceps. The flap is raised and then the rhexis is being initiated. As I'm tearing the capsule, I'm trying to get the feel. Now I realize that the zonules are alright, they're not too bad. The aim is to perform an adequately big rhexis so that the bulky nucleus comes out without damaging the capsular bag. So I'm trying to go under the pupil a little bit so that I have an adequately sized rhexis. Just to loosen up the nucleus from its attachments to the bag, I'm just trying to do a very minimal hydrodissection with very little fluid. Because these eyes with zonular weakness, the lens will be wobbly, and when they're trying to rotate the nucleus out, there is a small risk that the bag will also come out. There's a reason why I'm trying to ensure that the corticocapsular adhesions are broken. I'm nudging the nucleus around and observing the capsular bag. We want to know whether the nucleus movement is also causing the capsular bag to move. The rhexis seems to be stable, not moving, suggesting that the nucleus is well and truly free from its attachments to the capsular bag. Now is the time to maneuver the nucleus out of the capsular bag into the antechamber. And this is the stage where I would want to have wider pupil. Now I'm going to pull on these hooks so that the pupil expands much more. It's difficult for me to the capsular margin on my left side because I'm going to introduce my dialer there to wheel the nucleus out. I don't want the bag to come along with the nucleus. The antechamber is now filled with OVD. Now when I'm trying to maneuver the nucleus out, there is a risk that the capsular bag will come along with the nucleus. And the other problem is the rhexis margin I'm unable to identify very well because of the lack of staining. So in this situation, I need to be very cautious how my left syncytial hooks the equator. I don't want it to hook the rhexis margin accidentally. To show the maneuver, I'm going to slow down the video footage in slow motion so that we can understand what maneuvers I'm doing. The first maneuver is going to be the syncytial in my right hand is going to push the nucleus a little bit down and away to my right side, and then my left syncytial slides along with the nucleus towards the left side until it reaches the equator. So now I know that the syncytial is not engaging the rhexis margin, then it goes underneath the equator of the lens, and then the nucleus is wheeled out bimanually out of the capsular bag. The nucleus is quite bulky, it's going to occupy the entire antechamber, and because we have already used these hooks on the iris will also tent up. So there is a lack of space in the antechamber. We need to be mindful of this. And you can see the iris hooks are all standing vertically because the nucleus is pushing these hooks, and that's the reason why they're standing like that. And there is a small risk of the iris getting entrapped on the underlying vectors when you're trying to extract the nucleus out. So we need to be a little bit mindful of all these eventualities. The next important step here is to remove the hook which is gone through the main incision, because otherwise we can't extract the nucleus out. So the hook is out now, and I'm going to use a phaco sandwich technique to explant the nucleus out. So the vectors and the dialer go in. The hard nucleus is sandwiched in between these two instruments, and gently it's extracted out of the eye. The epinucleus and the cortex are then expressed out using viscoelastic. Once the visibility increases, now we realize that a couple of hooks have disengaged from the pupillary margins and a couple of the hooks are still holding on to it. So that's all right, and I'm just using passive irrigation to burp out all the loose cortex. I'm going to use bimanual I&A, and for using the same two proximal ports, so I'm going to remove these two hooks and use these ports to perform cortex aspiration. Now, because the pupil has been stretched now, the pupil is moderately dilated. I have reasonable visibility because of this moderately dilated pupil, but nevertheless during cortex extraction, I need to be careful that the chances of losing the bag will still be there even at this stage. In some quadrants, the fibers are too sticky and it's quite intimidating to venture in aspirating these small fibers because these posterior capsules will be extremely thin and very fragile. So need to be very judicious in deciding whether to attempt more number of times to remove these cortical fibers. I decide to stop here, inject the bag with OVD, and I'm going to introduce a CTR into the bag. Planned PMMA lens is then implanted into the capture bag. The two remaining hooks on the distal two ports are then removed. The last bit of attempt to remove this cortex is being done. The OVD both in front and behind the lens is irrigated out. Time to close. All the paracentesis wounds are hydrated. The conjunctival flap is being closed using glue. These are the first day post-op pictures. The patient's vision is 6/18 and she's quite happy. So in such extreme cases, our goal is to have a very safe surgery and try to be as minimalistic as possible. I prefer hooks to see well in such situations because these eyes also have other coexisting pathologies like loose zonules, and in general if we see well we have a better chance of doing a good job and also the surgery becomes much more safer. Pupil expansion rings might not be advised when you're doing manual smudge and cataract surgeries. The other option is to do a sphincterotomies. But the disadvantage of sphincterotomies, the expansion is going to be limited. It may not be very wide as we would like to have in certain intraoperative situations. So with all these points, my go-to device in a small pupil pseudoexfoliation with manual smudge and cataract surgeries is these hooks. So that was it. Thank you for watching and hope you found this helpful.